Hi, welcome back to my channel. Today I'm going to be talking about, in the third lecture series in the series of instruments, I'm going to be talking about something that is a sibling of an earlier instrument that I've spoken about. And as is the case with most of the siblings, there is one sibling or there is one kid that is the favorite of each parent. And today I'm going to be talking about that favorite one. So today I have with me a vacuum, or what we also call as the Ventouse. Why did I call it the sibling? This is the sibling of something that I had spoken earlier, and that is the forceps. This is something that is preferred a lot more these days by the new age obstetricians than forceps, and it has good enough reasons. While the earlier ones were extremely comfortable, and they were the ones, the earlier obstetricians were someone who just loved forceps, but nowadays this is being preferred more, and there are several reasons that we shall be talking about. So what I have with me right now, you can see this one is a vacuum. So yes, I just turned on the light. So I have with me a flexible vacuum, or what I can also call as a silicon base ventouse or vacuum system. I also have brought with me something that we don't use much nowadays, and that is the metallic vacuum cup. Today I have bought with me a smaller size, and the only reason that I bought the smaller size is for the demonstration purpose. But I have with me this, and it has a few very basic parts. One is your cup, the cup which is attached on the fetal head. I have also gotten a fetal head, so I'll be attaching it on the fetal head. So this is the part. Over here you have the point. You can see there's a hole over here, so you attach the tubing that comes from the system or from that machine that generates the vacuum, and it is attached over here. And here you can see there are areas for holding by the fingers, so a handle. Over here you can also control the amount of vacuum that is going in. The other one that I have with me is the metallic vacuum cup. We don't use it nowadays because the risk of fetal injuries are a lot more. What I don't have with me today is a Mitivac. Mitivac is something like a plastic that we also use as a vacuum system. That is something that we still use, but a metallic one is generally not preferred. So what is it about this vacuum that makes me say that it is preferred a lot more over forceps? The first point is that this acts a lot physiologically. When I'm going to be applying it to the fetus gets a lot of time, and it gets a lot of space as well for it to complete its rotation if it is not yet complete. And the delivery is also quite physiological, unlike forceps, wherein I'm actually just forcing that baby out from the vagina. Also, the risk of maternal genital injuries are significantly lower, but that comes at a trade-off. The trade-off is that this has a much lesser chances of delivering the fetus in comparison to forceps. So forceps is like कुछ भी हाल में मुझे वो baby को निकालना ही है. It comes at a cost of maternal perineal injuries, higher degree perineal tears, anal sphincter injuries, but this doesn't cause as much of it if you're careful. But the rates of successful delivery are slightly low, not significantly, slightly lower with this. So how do I apply it? So the first thing that I have to ensure is I have to ensure that a few prerequisites and indications are fulfilled. So what are the indications for using this one? They are the same as forceps. So what had we spoken in forceps? There are 3 to 4 very important indications. The most important is going to be fetal distress in second stage of labor. Now I had also mentioned in the forceps ka lecture that given that it has a higher chance of delivering the fetus, whenever there is fetal distress, I would prefer a forceps over vacuum. The also other point is that whenever I use this, it takes some time for me to achieve optimal vacuum or optimum suction pressure, and that is very crucial if there is fetal distress. So we don't prefer to spend that much of time or waste that much of time, and hence we prefer a forceps. The other indication is if there is second stage arrest. So basically the fetus is arrested, or arrested, I want to say that the baby is stuck in the second stage and it is not being delivered. So to expedite that, we'll use this. Apart from that, if the mother is not allowed to bear down because she has some heart disease or severe anemia or something of the sort, wherein she is not allowed to bear down, by bearing down I mean to say applying pressure with a closed glottis, which can precipitate multiple issues in her cardiac system, circulatory system, because of the Valsalva maneuver that takes place alongside bearing down. And lastly, if the mother is just too tired and she cannot bear down, she is too exhausted from the labor process, then at that point of time also we can use this. So basically this is a type of vaginal instrumental delivery along with forceps. How do I use it? The first thing is, once one of these indications is fulfilled, then I have to ensure that the prerequisites are also fulfilled. What are the prerequisites? I had spoken the other day in forceps ka lecture that the prerequisites include first of all maternal and then fetal. In maternal, the basic ones are the maternal bladder, urinary bladder should be empty. The cervix should be fully dilated. In this, they do say that you can apply it even after 8 centimeters, but I personally believe that you should not do that. It leads to very bad cervical tears. So the cervix should be fully dilated and well effaced. We should know very well what is the station of the baby. We should know very well what is the presentation. It cannot be breech. You cannot use this in breech. There is a Charmer's method wherein we use this for delivering breech, but it is kind of obsolete. You do not use it for that. Apart from that, in fetus, we need to know how the rotation is complete, where is the station, the membranes if they are absent or not. And the fetus, in this there are a few specific contraindications. Preferably avoid using this in a preterm fetus. The problem with preterm fetus is that the fetal blood vessels in the brain are very fragile. So the germinal matrix is very fragile and it leads to rupture of the vessels if you're going to apply too much of suction pressure. If that happens, then the baby will have cerebral and intraventricular hemorrhage. You do not want that, hence this is technically not allowed to be used before 34 weeks of gestation. So also, if a baby is having any coagulation disorder like von Willebrand disease, hemophilia, anything like that, then also you should, or alloimmune thrombocytopenia, you should not use this because this will lead to hematoma in the fetus. The suction pressure can also lead to intracerebral and intraventricular hemorrhage. So once the prerequisites are fulfilled, what do I do? First of all, I take this and I apply it. Now this is the fetal head, you can see. Over here is the anterior fontanelle and over here is the posterior fontanelle. So the ideal point of applying is going to be approximately 6 centimeters posterior from the anterior fontanelle. You see, this is the anterior fontanelle. So anterior fontanelle से 6 centimeter पीछे and posterior fontanelle से 3 centimeters आगे. So here it should be at the center of the ventouse is being applied. So यहाँ पे the center should be applied like this. Now you would ask me, why should the positioning be like this? If you can see over here, anterior से थोड़ा ज़्यादा पीछे है, posterior के थोड़ा ज़्यादा करीब है वो. This is my occiput over here, and this is my posterior fontanelle. So I have applied it like this. Now what is the reason for me to apply it? Side से भी देख लो. It is not completely over the vertex. It is not over here. This is not the way I am applying it. ये मुझे ऐसा उसको क्राउन जैसा नहीं पहना है, उसको शेंडी नहीं लगाना है. I have to put it slightly behind. Now what is the reason for that? The reason is something that I'm going to explain you using a doll that I have today. So look at this doll that I have with me today. In this doll, if I'm going to show you how the fetus or the baby is inside the mother's abdomen, it is in flexed position. We all know that. So flexed is basically ऐसे flexed रहता है. And whenever it is flexed, यहाँ से जब मैं vaginal examination करता हूँ, this is the part that I can see. So ये जो flexed head है ऐसा इसका flexed है. If I'm going to apply it too much anteriorly and then I'm going to pull it, this will lead to deflection of the head. This will lead to deflection. And अगर deflex हो गया तो baby deliver नहीं होगा. To maintain the flexion, I have to ensure that I apply it at the flexion point. The flexion point is what I showed you there. So when I apply it at the flexion point, this flexion is going to be maintained and the baby is going to be delivered. Also, it has to be in the middle. You can see it is in the middle. So we call this as the flexing median application. If you apply it anteriorly, then there will be deflection like this. If you apply it too much on one side, एक बाजू में ऐसा लगा दिया, so it will lead to lateral extension. Even that will be very difficult. We call that flexing or deflexing paramedian, depending on आगे लगा रहे हो कि पीछे. The ideal way is in the median, in the middle you have to apply, and at the flexion point, so that the flexion is going to be maintained. Fine. So how do I apply it? I also have a pelvis with me. Now this is a pelvis. The mother is lying down. You can see. I insert this inside and I apply it on the fetal head. Then I start a vacuum pressure of either 0.2 kg per centimeter square or in other units 100 millimeter of mercury. That is what I take the suction to initially. After that, gradually over a period of 2 to 3 minutes, I increase the suction pressure to either 0.8 kg per centimeter square or 600 millimeters of mercury. That is the maximum pressure that I have to create, maximum vacuum that I have to create. You do not go above that, because that can lead to scalp injuries, that can lead to bleeding inside the fetal brain. So 600 milligram of mercury or 0.8 kg per centimeter square. After that is done, I have to ensure that the mother is getting adequate activity. I give lignocaine local infiltration, then I also give an episiotomy, and I gradually pull it outside and I deliver the baby out. Whenever I'm doing this, if on 3 attempts the baby doesn't come down, then I have to understand, or there is popping off and ऐसे बाहर आ गया, निकल गया. If there is popping off 3 times, then you need to understand that this instrument is not working. You need to abandon the effort. You need to take that patient for cesarean section. Do not go for sequential application, मतलब पहले vacuum लगाया फिर forceps लगाया. It basically adds up the complications of 2 instruments and doesn't offer much benefit. That can be very traumatizing to the perineum as well. So do not go for sequential application. So to summarize, flexion point on the sagittal suture, एंटीरियर fontanelle से 6 सेंटीमीटर पीछे, पोस्टीरियर fontanelle से 3 सेंटीमीटर ऊपर, इन द सेंटर, इन द मीडियन, लाइक दिस. सो फ्लेक्सिंग मीडियन पोजिशन, मैंने ऐसे लगाया इसको, एंड देन आई पुल्ड इट आउट. वंस द बेबीज हेड इज डिलीवर्ड, आई शैल रिमूव दिस एंड देन आई विल डिलीवर इट. आई कैन ऑल्सो यूज इट फॉर ऑसिपिटो पोस्टीरियर. मैंने अभी ऑसिपिटो एंटीरियर दिखाया, दिस इज ऑसिपिटो एंटीरियर. नाउ मैंने सेम जैसे लगाया, इसको नीचे इंश्योर किया और ये बाहर निकाल दिया. So that is it about Ventouse application. Now the next and the last question is going to be, when and how would I prefer vacuum over forceps? So vacuum किधर better and forceps is not that good, and in what conditions is forceps better than vacuum? So now that I'm talking about vacuum today, I'll first mention that first of all, this ensures a physiological delivery. So even if the head is not rotated, it will ensure that this rotates खुद से and baby's head is rotated along with it. So that is the first thing. Secondly, even for slightly higher station like +1 or +2, I can use this very comfortably and ज़्यादा trauma नहीं होगा. Secondly, lesser rates of perineal trauma. How do I apply it? Once I have put it inside, मैं ऐसा इसको पकड़ता हूँ and मैं 360 degree I move my finger to ensure there is no maternal vaginal tissue that is coming alongside its margins. सो ऐसा उंगली मुझे घुमाना है, सो दैट आई एंश्योर कि इसमें कोई टिश्यू नहीं आ रहा है, एंड देन स्टार्ट इंक्रीजिंग द प्रेशर सो दैट नो मैटरनल टिश्यू इज coming inside that vacuum cup when it is applied on the head. So once I am done putting this like this, then I shall be moving my finger on 360 degrees to ensure there is no maternal tissue that is coming inside. Apart from that, the required force for delivering this is also significantly lower. So these are the reasons, or these are the places where I shall prefer vacuum over forceps. The other way around, when do I prefer forceps over vacuum? The first is in fetal distress, when I need to directly deliver, immediately deliver. Secondly, if this is a IUFD, so in IUFD there is going to be maceration, all the tissues are going to be very soft, and this won't apply very well on the fetal head, fetal scalp, which is completely soft and loosened out, lax हो चुका होता है. Next, I also cannot use this on breech delivery. Breech में I have Piper's forceps that I can use for delivering the aftercoming head. And lastly, I also need to know that a forceps is an instrument that is giving you a much higher chance of delivering the baby successfully than a vacuum does. Also, in a preterm fetus, you cannot use a vacuum, you have to use a forceps. So that is it about Ventouse or vacuum delivery. I hope if you are getting this instrument in the exam, you should be picking it up and just answer this question really well. So I shall meet you again in the next session on our instruments. Until then, this is Dr. Aditya signing off.